Good afternoon. I have a fun topic to present today on the management of symptomatic Caliceal Diverticular stones in the modern era of robotic surgery. I'd like to start off first with a cautionary tale. So this is a 43-year-old man who presents to an outside emergency room with right upper quadrant pain, and a non-contrast CT scan is performed showing a 1 centimeter left renal stone without evidence for obstruction. The patient is then referred to urology. Of course, the urologist knows what to do with 1 centimeter left renal stones. So the patient sees the urologist, and at this time his right upper quadrant pain had resolved. The urologist then treats him with 2 sequential left shockwave lithotripsy procedures, but there's no significant change in the stone burden after 6 weeks. And worse, the patient now has developed intractable left flank pain and can't work. So we've definitely made this man worse. Why is that? Well, this stone is actually located in a Caliceal Diverticulum, something that was not appreciated from the non-contrast CT. And this is an important issue because we're well along the path away from contrast imaging to work up most symptomatic stones in the emergency room. When I was a resident, we primarily did IVPs, and it was easy to identify Caliceal Diverticular stones in that setting. But today we're using mostly non-contrast CTs or even ultrasounds in some settings. And this is a modality that's easy to miss, Caliceal Diverticular. So Caliceal Diverticula are like the mouse and the mousetrap. It's a simple problem that often requires a complex solution. Now, there was a nice meta-analysis published in 2018 looking at all the literature on management of Caliceal Diverticular stones. Unfortunately, the bad news is that the conclusion was that there is not enough high-quality literature to adequately evaluate what the ideal strategy is for managing these stones. So I'm not going to give you the final word today. What I am going to do is try to provide a basic framework for clinical decision making when you're faced with these complex but very interesting endourologic patients. So Caliceal Diverticula were first described in the 1940s and has an incidence of about 0.6% of the population. We generally saw 2 to 5 of them per 1,000 IVP examinations. Of course, fewer are going to be picked up on non-contrast CTs. Only about 3% are bilateral, and you see them in both sexes with equal frequency. They're more commonly oriented posteriorly in the kidney, and more than 50% are located in the upper 1/3 of the kidney. These are essentially a developmental anomaly related to a lack of generation of the 3rd and 4th order ureteric buds, perhaps a vascular process in origin. It's important to remember that these are diverticular cavities, and although they're lined with transitional epithelium, they do not secrete fluid. We have identified transitional cell carcinoma or urothelial carcinoma in diverticula. They are lined with transitional epithelium. The filling of these diverticula, however, is believed to be solely due to retrograde passive filling and not active filling. They're usually collected to a minor calyx via narrow infundibulum. Again, remember, retrograde passive filling. So most of these diverticula are asymptomatic and found incidentally on contrast imaging, but they can be associated with chronic flank pain, hematuria, or recurrent urinary tract infections. They have some potential for poor drainage and urinary stasis and inflammation. And stone formation is relatively common and is a common indication for surgery. So stones are seen in about 10 to 40% of Caliceal Diverticuli. The etiology is somewhat controversial, but likely is a combination of urinary stasis and metabolic abnormalities that are pre-existing in the patient. Some likely become symptomatic only after they develop these stones. So here's an example of a study. Most studies have documented a similar metabolic abnormality in stone formers with and without Caliceal Diverticula. So it's not something unique to the Caliceal Diverticula. The take-home message here is that most patients who develop a stone in a Caliceal Diverticulum have urine metabolic parameters similar to stone formers and not to normals. If you look at these diverticuli and actually sample the fluid from the diverticuli, you actually see something quite interesting. Stones form in these diverticuli despite an environment lower in calcium oxalate, and that argues perhaps for urinary stasis as a mechanism. So why do these people get flank pain? Well, there's a couple of reasons. There's a progressive accumulation of urine with distension of the diverticulum, and also the possibility of progressive inflammatory changes from urinary stasis, stones, infection, etc. So here's an example. Active transport mechanisms move the urine out of the kidney. We know that through ureteral peristalsis. However, these mechanisms can also fill a Caliceal Diverticular. So here's an example of a Caliceal Diverticula, and you can see that there's filling of the diverticula. Now we have a stone. What happens if that stone then blocks the neck of the diverticula and there's passive filling of the diverticulum? Well, you can see that that's going to stretch the diverticulum and potentially cause symptoms. There is a clear correlation of pain with progressive filling and size of diverticula. However, abrupt decompression is not always going to provide prompt pain relief, as you might expect. Be cautious when you counsel these patients in terms of what to expect after treatment if you're providing only decompression. There's also an inflammatory hypothesis for why they're symptomatic. Minimal inflammatory findings can be seen on imaging. Removal of the stone alone doesn't always lead to symptom relief, arguing again that it's not just a relief of obstruction. And again, the urine within the diverticulum generally is not turbid, and the diverticular mucosa does not usually appear irritated under endoscopy. So here's an example of a 38-year-old woman with a symptomatic Caliceal Diverticular. She underwent a percutaneous approach to treatment and did well after that procedure. However, a few months later, the diverticulum reaccumulated and she was back having further pain. She underwent a partial nephrectomy and then had long-term resolution of her pain afterwards. Here's an example of a 31-year-old with a symptomatic Caliceal Diverticulum. And in this case, the neck of the diverticulum was accessed endoscopically and a stent was placed into the diverticulum. In that case, the patient had resolution of their pain just with decompression. Let's think about our surgical treatment goals. Obviously, we want to relieve diverticular obstruction, and to do so, we need to remove calculi and widen the communication with the main renal collecting system. We would ideally like to obliterate the diverticulum so that new stones wouldn't form and new obstruction wouldn't occur. And to do that, we would have to either ablate the diverticulum or remove it. So these are two separate surgical treatment goals. So in the 1970s, options for treating these diverticular were pretty limited. It was open surgery and pretty much nothing else. But in 2020, we have a whole range of different approaches that we might apply to this problem. So what I'd like to do is go through some of these and give you a little bit of a framework to understand how you might choose between all of these minimally invasive options. So we've all watched this expansion of minimally invasive surgery and endourology, from shockwave lithotripsy to ureteroscopy and percutaneous surgery through laparoscopic and robotic surgery. Well, we can think about the treatment approaches for these diverticular stones along a spectrum, from minimally invasive and conservative approaches to maximally invasive and aggressive approaches. Shockwave lithotripsy obviously is probably the most conservative and minimally invasive approach, with open surgery being the most aggressive and maximally invasive approach. It's also true that as you move up the scale from minimally invasive and conservative to maximally invasive and aggressive, you see a more definitive solution to the diverticulum. All right, the early minimally invasive and conservative approaches are generally aimed at relieving obstruction. The more aggressive approaches are primarily aimed at obliterating or removing the diverticulum, which perhaps explains why they're more definitive. So let's look at shockwave lithotripsy. So this is a study comparing a series of shockwave lithotripsy series, and the take-home message is that the stone-free rates in Caliceal Diverticula are very poor, so less than 25%, and in some cases as low as 4%. This doesn't really surprise us because most of these fragments are trapped within the diverticulum, and you're not going to have good clearance of stones from the kidney after lithotripsy. Symptom-free rates are also rather poor, ranging between 36 and 75%. So not a great approach for managing Caliceal diverticular stones. I think it should be used very selectively in patients who are perhaps very high risk for more aggressive surgery, who are willing to accept a lower stone-free and symptom-free rate. Generally, it should not be the first-line therapy for all patients with symptomatic diverticular stones. And sometimes shockwave lithotripsy can make other approaches like percutaneous or laparoscopic approaches more difficult in the secondary setting. It can also make asymptomatic patients with diverticular stones worse and make them more symptomatic. So be careful of that. So asymptomatic patients with Caliceal diverticular stones generally don't need surgical therapy. Avoid the temptation to make the cure worse than the disease, as was shown in my first cautionary case. And be vigilant to exclude diverticula before you treat asymptomatic stones that are seen on non-contrast imaging. So the next step up the hierarchy is to use ureteroscopic management, and there are some advantages to this. It's minimally invasive, generally a procedure with rapid recovery, and relatively few downsides to an attempt. It can be technically challenging in some cases to identify the ostium into the diverticulum, so this can be a somewhat difficult case. The goals of this are to relieve the obstruction and perhaps to remove the stone. It's really not realistic to be able to ablate the diverticulum unless it's a very small diverticulum. You need flexible ureteroscopy, you need a dilating balloon generally. Often you'll need the laser if you're going to approach a stone in the diverticulum, and perhaps cautery if you're going to do an ablation, although my sense is that electrosurgical ablation ureteroscopically is not a very effective strategy for managing diverticula. So the goals of this procedure: you identify the ostium, you cannulate the ostium with a wire, you balloon dilate to provide access, you insert your ureteroscope into the diverticulum, you can then address the stone in a standard manner, and then usually incising the ostium to create a larger opening is a wise decision, and then you can place a stent coil into the diverticulum to keep it open. If you have difficulty finding the diverticulum, one thing that you can do is to inject blue dye into the kidney in a retrograde manner that will fill the diverticulum. And then as you wash the rest of the blue dye out of the kidney, you'll often see blue dye escaping from the diverticular orifice when you do your ureteroscopies. This can be very helpful. I like to use multi-length stents for diverticular procedures. They tend to have a larger coil structure that keeps them in the diverticulum. This is probably the only situation where I like to use multi-coil stents. Watch out for these because they can become knotted if you're not careful. So with ureteroscopic management, basically the take-home message is that this is clearly superior to shockwave lithotripsy for managing symptomatic stones. However, success rates are still relatively low. So as we work up the hierarchy, we move into percutaneous management. And this is really the gold standard for management of diverticular stones, at least prior to the era of robotics. So this is a large meta-analysis looking at percutaneous management. You can see that these numbers look a lot better. Stone-free rates are in the between 70 and 100%. Symptom-free rates are also better, 80s to 100%. So certainly a very reasonable approach. And since most of these, or many of these diverticula are posteriorly based, this is a good strategy. In general, a removal of the stone and release of obstruction with or without effective diverticular ablation is the goal. This can be a challenging percutaneous surgery. These are often upper pole posterior lesions. They do generally require direct access to the diverticulum, and sometimes it's difficult to pass a wire directly into the main renal collecting system. Often these diverticuli provide limited space for coiling of wires, and there may be thin parenchyma overlying the diverticulum, which may not hold a nephrostomy tube well. Really, it's important if you're going to do these cases percutaneously that you're comfortable placing your own access. This is a difficult case to do if you're asking your radiologist to place access for you in the radiology suite. Use all your OR advantages to succeed in these cases. The unfortunate reality is that upper pole access is necessary in the majority of diverticular cases, often supracostal access, and that does increase your risk of pneumothorax. It's important to stay as lateral as possible and to decrease that risk. And strategic planning is really individualized. We generally do a combined above and below approach to percutaneous surgery on a split leg table. We have the ability to go retrograde and antegrade at the same time. Management of percutaneous approaches include placing the patient prone. Prone cystoscopy is performed, catheter is placed into the ureter, we fill the caliceal diverticulum with contrast. We then perk directly into the diverticulum and pass the wire ideally into the renal collecting system. We then dilate into the main renal collecting system, remove the stones via standard PCNL methods, cauterize the mucosa, and then place a large bore access into the ostia to help with scarification. Cauterization can take many forms. You can use a Bugbee, you can use a long resectoscope with a roller ball for larger diverticula. Well, why would we go more nuclear in these settings? Well, sometimes PCNL fails in the case of diverticula. It can be difficult to do in anteriorly located Caliceal diverticula, and is an issue because of very thin overlying parenchyma or patients who cannot be placed prone, for example, for surgery. Sometimes body habitus can make percutaneous access unusually challenging or dangerous, and sometimes it's patient or surgeon preference. When we look at laparoscopic and robotic approaches to diverticulectomy, they take two forms: the form of true partial nephrectomy or a diverticulectomy, which involves unroofing, closure of the ostia, and removal of the stone and ablation of the mucosa. And this tends to be our favorite approach. Vascular clamping is generally necessary if you're going to do a partial nephrectomy. These are rather difficult partial nephrectomies because they generally require extensive resection of kidney parenchyma. These are generally deep endophytic lesions. And this can make this a more challenging partial nephrectomy on your learning curve if you are not facile already with doing endophytic renal tumors. So there is some danger in that strategy. Ultrasound can be critical in terms of identifying and locating the diverticula for that approach. I do like the advantages of diverticulectomy. This is a procedure that can often be performed without vascular clamping if the parenchyma overlying the diverticulum is relatively thin. There's really no question that you're treating the diverticulum because you're opening it. It's easier to plan the approach with ultrasound, and you don't remove much of any viable kidney parenchyma in this process. It's also just technically easier. So here's an example of that. We do some initial hilar dissection, although we don't generally clamp these patients. Having access to the vessels is useful in case there's more bleeding than you anticipate. You expose the renal surface where the diverticulum is. We then perform ultrasound to identify its location and confirm it. So again, it is generally an endophytic structure. We will then get vascular control if necessary. Again, this may not be necessary in most diverticula. We then open the diverticula. In this case, you can see the diverticula opened and a small stone at the base. You can see that small stone. We remove that stone. We then suture the ostia to close it so that it doesn't communicate with the collecting system any further. And then we oversew the parenchyma, usually just on the edges to prevent bleeding. And if things were clamped, we'll unclamp. But again, I would say we clamp only about 20% of these diverticulectomies. We can then cauterize the diverticular mucosa to help with scarification or place Surgisil into the cavity, then place a drain. So there's not much literature on this approach. It's generally fairly favorable, as you would expect. Stone-free rates are very high, generally 100%, and symptom-free rates are also relatively high. Understand, though, the jury is still out since there are not a lot of published studies on this approach. So I would consider this as a simplified algorithm for managing Caliceal diverticular stones. If they're asymptomatic, observe them, maybe do a metabolic workup, but don't intervene. If they're symptomatic, I generally offer them an attempt at ureteroscopic management and quote them a roughly 50-50 chance at success. If ureteroscopic management is not successful, then we'll move on to assessing whether there's significant overlying parenchyma. If there is, then where's our location? If it's posterior, then perhaps a percutaneous approach is the appropriate one. If it's anterior, I'm generally going to approach this laparoscopically or robotically. Similarly, if there's very little overlying parenchyma, A laparoscopic approach may be better in those cases. So just a few challenging cases to test you at the end here. This is a 50-year-old man with right flank pain for 3 years, no prior geosurgery, no prior nephrolithiasis, and no urinary tract infections. He has a Caliceal Diverticular. This is a patient who underwent a ureteroscopic management approach. We balloon dilated the ostia and were able to clear the stone and open him up, and he had no further requirement for intervention. So here's an example of one where a ureteroscopic approach works. Here's that patient I mentioned earlier, 38-year-old woman with left flank pain, posteriorly oriented Caliceal Diverticular, had failed an outside attempt at ureteroscopy, and had 8 months of relief following percutaneous management, but unfortunately, her symptoms recurred after reaccumulation of fluid in the diverticular cavity. This patient was then taken for a partial nephrectomy and then had subsequently resolution of her symptoms. So here's a 17-year-old woman with right flank pain, nausea and vomiting, had shockwave lithotripsy without improvement and failed ureteroscopy. They could not find the ostia. This is one where we approached this as a robotic Caliceal Diverticulectomy, and you can see that this was a nice visualization of the diverticulum. This was a procedure that was performed off clamp, and no further surgery was required after completion. 22-year-old woman, 1-year history of right flank pain and nausea and recurrent infections, had failed ureteroscopy in the past. They underwent a percutaneous approach, which was complicated by a renal pleural fistula, which resolved rapidly with drainage. Now she had reaccumulation of pain and reaccumulation of fluid in the diverticula. What are we going to do for this patient now? Well, generally speaking, this is a case to move on to robotics. So take-home messages. Stones in Caliceal Diverticular are simple problems that often require complex solutions. These are patients who have urine characteristics similar to stone formers, so stone prevention approaches, even after treatment, are appropriate. Although the cause of pain remains controversial, an obstructive component is likely. And watch out for treating asymptomatic patients with diverticular stones, particularly with shockwave lithotripsy, as this can worsen the situation considerably. A broad range of techniques have been applied to treat diverticular with stones, and retrograde ureteroscopic approaches are far more effective than lithotripsy and relatively low risk, but success rates are still not ideal. Percutaneous approaches remain the gold standard, particularly for posterior diverticular with thick overlying parenchyma. However, laparoscopic and robotic approaches are well suited for larger stones, anterior diverticula, and those with thin overlying parenchyma. Unfortunately, published outcomes remain relatively sparse in these patients. Thanks for your attention and good hunting.